Welcome to this session with me, Dr. Vaishnavi, and we are going to do some MCQs for discussion for the INI-CET examination. So let's begin the session with the first question. A 70-year hypertensive patient presented to you with a left-sided hearing loss and tinnitus. Audiometry suggests that there is a pathology in the inner ear. Where are the deter cells located? Is it in the organ of Corti? Is it in the utricle, saccule, or the spiral ganglion? Yes, very good. That's the organ of Corti. That's the right answer. So basically, if we see the organ of Corti, that is the sensory neuroepithelium that is present in your inner ear, where we have got type 1 hair cells, type 2 hair cells, and some supporting cells. What are the supporting cells? They are the cells of Dieter and cells of Henson. These are going to be your supporting cells. So now if I ask you which is single, which is inner, which is afferent, what is your answer going to be? Can you tell me which is a single hair cell, which is a cell that is arranged in a single row, a cell that is having, single layer? Type 1 cells, very good, is going to be your single. As the number suggests, 1 matlab single, so type 1 is single. They are arranged in one row. And third of all, because 1, if I write Roman digit like this, it resembles the alphabet I, so it's also called as inner hair cells. And the first alphabet in your English is A, so that is how you remember that these are your afferent hair cells. Now, because they're afferent hair cells, they will secrete excitatory neurotransmitters. Right? Type 2 hair cells are going to be your multiple hair cells. They are not arranged in one row, but they are arranged in multiple rows. They are also called as outer hair cells. They are efferent in function, which means that they're going to control the type 1 cells and they secrete inhibitory neurotransmitter. Right? So this was your MCQ of the past, where they asked you of type 1 and type 2 hair cells for the INI-CET. I just twisted the question a bit and asked you about cells of Dieter and Henson. So is this clear to everybody? Any doubt in this question? No, this was also again a PYQ, and also I have handpicked some previous year questions that I'll be discussing in the end in the last 5 years of INI-CET. The rest of the questions I have incorporated them during the discussion, during the test itself, but there were a few questions which I haven't put in the test, so that I'm discussing in the end, which are your previous year INI-CET questions. I'm going to give you the list of topics also that are important for your exam. So can you tell me what is the joint that is marked in this image? They have marked you a joint and they're asking you. Again, this is a standard INI and a NEET question. They can give you this ossicle and ask you what is this. They can give you this ossicle and ask you what is this. They can give you this ossicle and ask you what is this. Right? So we're talking of malleus and incus. Between the incus and malleus, we have got the incudomalleolar joint, and incudomalleolar joint is a saddle type of joint. But if they would have marked this and given to you, what would your answer be? If they would have given you that image showing to you this particular structure that is marked, what would your answer be? Would it still be incudomalleolar? Yes, that would be a ball and socket type of joint. So incudostapedial joint is ball and socket type of joint. Now match the following, because match the following helps us to learn more amount of information in one go. I've given a lot of match the following questions to all of you, and INI especially has a lot of match the following questions in your exams, which is why we're going to practice them here. Processus cochleariformis, pyramid, tympanic membrane, and facial nerve are the structures that we have in the middle ear. Now you're supposed to match them. In which wall are you going to find these structures? Processus cochleariformis will be in which wall, pyramid is in which wall, tympanic membrane is in which wall, and facial nerve is in which wall. So what is processus cochleariformis? It is a projection on the medial wall of the middle ear, and that is the area where the tensor tympani makes its turn. Pyramid is located in the posterior wall, where you have got the stapedial muscle originating. Tympanic membrane is present in the lateral wall of the middle ear, and that separates the middle ear from the external auditory canal. And facial nerve is present on the medial wall, and it goes from the medial wall to the posterior wall. So we need to have 1C, 2D, 3A and 4B, which is given in your option D. Now let's move to the next question. Type 1 tympanoplasty, type 3 tympanoplasty, type 4 tympanoplasty, type 6 tympanoplasty. You're supposed to match with columella, sono-inversion, myringoplasty, cavum minor. I'm waiting for your answer. So we know that Wolstein's classification. So the name of the classification system is called as the Wolstein's classification. So what does Wolstein's classification say? Yes, 1 is C, right? We know that 1 Type 1 is myringoplasty or repair of the tympanic membrane, where the graft is placed on the first ossicle, which is malleus. So if you see here, even if you don't match the rest of the options, there is only one option that says 1C. Rest of them don't even say 1C. So you're very confident, even if the rest of it you don't know, you can still go to the right answer. So 1C, 2D, 3A and 4B. So that is your right answer. So type 1 is when you place the graft on the malleus. Type 2 is when you place the graft on the second ossicle, which is your incus. Type 3 is going to be when you're going to place the graft on the head of stapes, which is your cavum minor. Then we have got type 4, where you're going to place the graft on the foot plate of the stapes. We also call it as columella or cavum major. And then you have type 5 tympanoplasty, where you're going to put the graft, or you're making a hole in the lateral semicircular canal and then placing the graft. And sixth, you're going to place the graft on the round window and reverse the sound process, so that the sound goes and hits the round window first and then the oval window. And that process where you reverse the process of sound transmission is called as sono inversion. Okay, so I think that is also sorted. Now let's quickly look at the next match the following type of questions. Vestibular aqueduct, cochlear aqueduct, endolymphatic duct and ductus reunions. These are very confusing in exams. You could have a lot of confusion with the names of these ducts. So quickly tell me, what do you think is the right answer? Yes, so let us see what is vestibular aqueduct. So before we go into that, let's look at the anatomy of the inner ear quickly. So we know that there is a central chamber in which we have got the utricle and saccule. From the utricular duct and saccular duct, we form a duct or a union of duct which is called as the endolymphatic duct, and the endolymphatic duct opens in the endolymphatic sac. Now, saccule is connected anteriorly to the cochlea via a duct. And what is this duct called as? Cochlear duct. Posteriorly, the utricle will receive the opening of semicircular canal ducts. Right, so we have got the cochlear duct and we have got the semicircular canal duct. Now the bony covering over the endolymphatic duct, what do you call this bony covering? Vestibular aqueduct. Bony covering over the utricle is called as elliptical recess. Over the saccule is called as spherical recess. Over the cochlea we have compartments, one above and one below. So the above is called as scala vestibuli and below is called as scala tympani. And covering the semicircular canal ducts is your bony semicircular canal. So I hope this inner ear structure we already know. Now what is vestibular aqueduct? Vestibular is the bony covering over the endolymphatic duct. So let's see which option says 1B, even if we don't know the other options. Yes, so we know now we know that option B says 1B. Let's check the other options here as well. Cochlear aqueduct. What is cochlear aqueduct? It is the duct connecting the scala tympani to the subarachnoid space. Is that true? Yes. So from the scala tympani to the subarachnoid space, we have a duct, and this duct is called as cochlear aqueduct. And what is the function of cochlear aqueduct? It's going to transmit the perilymph, which is an ultrafiltrate of CSF, from your subarachnoid space into scala tympani to fill the entire space between the bony labyrinth and membranous labyrinth. What is endolymphatic duct? Union of saccular duct and utricular duct together will form endolymphatic duct. So that is right. And what is ductus reunions? Ductus reunion is the small duct here that is connecting your saccule with that of the cochlear duct. So that's your right answer. That's right, Pratibha. I hope all of you got it. Now let's look at the next question. Match the following. What are the causes of referred otalgia, and from where do you get this referred otalgia? Primarily because this is also a very important PYT when it comes to INI-CET exams. They have given a lot of times questions from referred otalgia. So post-tonsillectomy, tonsil is in your oropharynx. So in oropharynx, what is the sensory nerve supply? It is your glossopharyngeal nerve. And if there is any structure that is involved in the oropharynx, the tonsils or the base of tongue or post-tonsillitis or post-tonsillectomy, if a patient complains to you of pain in the ear, you should think of the glossopharyngeal nerve. So any oropharyngeal lesion or pathology. What is the cause that is responsible for referred otalgia? It is your glossopharyngeal nerve. Any lesion in your oral cavity, anterior 2/3 of the tongue, buccal mucosa, teeth or TM joint. So anything in the oral cavity, what is the nerve responsible? It is your trigeminal nerve, because we have the lingual nerve there, and lingual nerve is a branch of your trigeminal nerve. Then we've got Arnold's nerve. What is Arnold's nerve? It is the auricular branch of the vagus nerve, and this vagus nerve in your orodigestive tract, it is supplying your larynx and your hypopharynx. So any pathology of the larynx and hypopharynx will be mediated via which nerve? Via the auricular branch of the vagus nerve, which we call it as the Arnold's nerve. And what is Jacobson's nerve? It is the tympanic branch of the glossopharyngeal nerve. So let's look at the correct answer. 1C, 2D, 3A and 4C. That is the right answer. So here we have got 1C, 2A, 3D and 4B. That is your right answer. Got it? Yes, Laksha, that is the right answer. Now let's look at the 7th question. A patient presents to you with gradual onset of unilateral sensory neural hearing loss with poor speech discrimination. So look at the word here, poor speech discrimination, normal middle ear function. Again, this was a similar question that was tested prior in your INI-CET. Which diagnostic test is most important? Okay, so Lakshya says C. What about others? Subhash, you also say C. Let me see what others have to tell. I'll wait for a second to get your answers. So whenever you have a question which says SNHL, and if the word poor speech discrimination is given to you, you have to think about which pathology. You have to think about retrocochlear pathology. So please make a note, whenever there is a patient with poor speech discrimination, you should think about retrocochlear pathology. They can also say that the patient can hear the sound but cannot understand the speech or the words spoken. That is called as poor speech discrimination. So the test that you do for retrocochlear pathology is going to be your BERA or auditory brainstem response. So that is your right answer. Very good. A slowly progressive right-sided conductive deafness in a middle-aged female who has a normal drum and a normal Eustachian tubal function. Tuning fork test finding will show what? Again, this is a PYQ of INI-CET. A twisted bit that I have put in here. They had asked you what was the diagnosis. I'm asking you what will be the tuning fork test finding. So if there is a right-sided conductive deafness, okay, what are we going to expect on Rinne? Rinne is negative in conductive hearing loss, positive in normal and sensory neural hearing loss, right? So if right-sided conductive deafness, Rinne has to be negative on the right side. They haven't given you anything about left-sided ear, so let's presume it is normal. So let's look at an option which has negative on the right and positive on the left. So if we look, this option can be ruled out. The rest of them have negative on the right, positive on the left. Now we are going to check. Whenever there is a conductive deafness, the Weber will go towards the diseased side. And if the disease is in the right ear, where will the Weber go? Towards the right side. So with this, Weber to left is ruled out. So what's the right answer? Negative on the right, positive on the left and Weber to the right. So this is how you get to the right answer, and I see almost all of you have got it right. Let's go to the next question. A pregnant woman in 3rd trimester complains of hearing her own sounds, which means that there is autophony. Autophony is the patient is able to hear her own sounds. Examination shows the tympanic membrane movements are synchronous with respiration and exaggerated when the nostril of the contralateral side is occluded. Your diagnosis is, what do you think? See, they are telling to you that the tympanic membrane movements are synchronous with respiration, which means that whenever there is inspiration, the air is going to enter inside and push the tympanic membrane outwards. During expiration, the air will go in the reverse direction and retract the tympanic membrane. So bulging, retraction synchronous with respiration. Why should this happen? This should happen when the Eustachian tube doesn't have a tone. It is patulous. When will the Eustachian tube become patulous? Especially in pregnant women, in patients who are obese, in those patients in whom you see a rapid weight loss. Nowadays, there is a lot of a lot of people are trying to lose weight with so many medications also, like Munjaro, etc., and they lose the weight rapidly. So what happens is that near the eustachian tube there is a pad of fat present called as the Ostman's pad of fat, and that Ostman's pad of fat, if it resorbs very quickly, the eustachian tube becomes loose, lax, and doesn't have a tone. That we call it as patulous eustachian tube. So whenever air goes inside, it will go into the middle ear, causing bulging of the tympanic membrane. When the air, during expiration, the air goes in the reverse direction to cause retraction. And because there's a lot of air that is in the middle ear, the patient has echoing of the sounds, which we call it as autophony. So I hope everyone has got the right answer here. Yes, Pratibha, Ozempic, Munjaro, all of these drugs can cause rapid weight loss, right? Okay, a 17-year-old female presents to you with painless otorrhea, foul-smelling scanty discharge. So what do you think? Only with this one line and two buzzwords, can you tell me what's your diagnosis? Painless otorrhea, foul-smelling discharge. What comes to your mind immediately when we're talking of this? We're thinking about a middle ear disease for sure. And where do you get foul-smelling discharge? Where do you get scanty discharge? Where do you get painless discharge? Yes, it's seen in unsafe type of CSOM or cholesteatoma. One of these two, right? Because rest of them will not present to you with scanty, foul smell, etc. Now we'll read the next line. The patient is found to have a middle ear mass and is scheduled for canal wall down mastoidectomy. So what is canal wall down mastoidectomy? It is MRM. In which conditions do we do MRM? We do it for unsafe type of CSOM or cholesteatoma. So now whatever keywords we knew, are they matching with the next line? Yes, perfectly. Now you're doing this MRM for what? To create a safe and dry ear, which further gives you an idea that we're definitely on the right track thinking about unsafe type of CSOM and cholesteatoma. The most common middle ear mass. So if they're asking you middle ear mass, would you think of CSOM or would you think of cholesteatoma? You would think of cholesteatoma. So now you know what the question is about, and now you're supposed to answer. This middle ear mass tends to recur in which anatomical area? Right? So for that you will have to see the image. They have given you the image with asking you where does the recurrence happen. So if you see the first image, the structure marked is this. What is this space you need to identify between the pars flaccida and neck of malleus? Second image is showing to you a space above the pyramid. Third image is showing to you a space below the pyramid. And fourth image is showing to you a mastoid antrum. So where does the most common middle ear mass recurrence happen? All of you should tell me this very quickly. Yes, Pratibha, that is sinus tympani. But where is sinus tympani? Is it a suprapyramidal recess or an infrapyramidal recess? Suprapyramidal recess that you see here is your facial recess. And the infrapyramidal recess that you see here is your sinus tympani. Right, very good, Lakshya. So this is your right answer. The most common middle ear mass tends to recur in your sinus tympani. What is this space here between the pars flaccida and the neck of malleus? We call this space as Prusak space. So what is this Prusak space? This is the space between the pars flaccida and the neck of malleus, and this space is the most common site of origin. So this is the most common site of origin of cholesteatoma. And when you do a mastoid surgery, the largest air cell that you see here is your mastoid antrum, where you remove the disease first. So I think everyone is clear. Just a few words about this facial recess. Facial recess is between the vertical portion of the facial nerve and the chorda tympani nerve. So vertical portion of the facial nerve and chorda tympani nerve. Superiorly we have the incus. What is this facial recess used for? This is used for cochlear implant surgery. So which surgery do we use this? Cochlear implant surgery. And the name of the approach is called as posterior tympanotomy approach. So you're approaching the middle ear from the posterior route, not from the canal route. That is why it is called as posterior tympanotomy. So these are important things that you should know about the 4 images. So Abhi, I hope everyone has understood this. Quickly give me thumbs up if that's clear with everyone. Right. So the investigation shown is used in the diagnosis of. So you can see here there is an image that is showing to you that there is an electrode going through the tympanic membrane and sitting on the basal turn of cochlea. So, and it is also showing to you something like SP by AP, and it is showing to you SP by AP is more than 50%. So which investigation are we talking about when the SP by AP is more than 50%? Yes, very good, Pratibha. That's the right answer. It is your Meniere's disease. And what is this investigation called as? This is called as electrococheography. So what is electrococheography? This is a test where transtympanically, meaning through the tympanic membrane, we are inserting an electrode which is placed on the basal turn of the cochlea or the promontory, and we are able to get the electrical activity or impulses happening in the promontory or in the basal turn of cochlea on a sound stimulus. And this particular investigation is the investigation of choice for patients with Meniere's disease. So where do we use this? This is the investigation of choice for patients with Meniere's disease. Right? So that's about it. Let's go to the next one. Match the following. Rhinitis positive is seen in which condition? Weber to the right indicates what? What is Stenger's test used for? And what is the use of absolute bone conduction test? So mind you, in the NEET FMG examinations of 2025 and FMG 2026, there were 2 questions from this same chapter, assessment of hearing. So this becomes a very, very important topic because there were 2 questions which came from the same topic. So assessment of hearing is absolutely essential for you to revise. What is Rhinitis positive? Rhinitis positive could be seen in normal or SNHL. So let's say you don't know the other options. Let's see which 1B. Only option A. So obviously that so perfectly you know that it is 1B, rest of it you can rule out. But let's confirm, is this absolutely right? Weber to the right side, meaning Weber to the right side indicates on that side there is a conductive hearing loss, which is true. Stenger's test is used for malingering. So what is Stenger's test? I'll keep 2 tuning forks at the same distance from the external auditory canal and I'll close the patient's eye. Normally when you move the tuning fork closer to the pinna or farther from the pinna, there should not be any variation or increase and decrease in the intensity of sound as perceived by the patient. But the patient will say that they are able to hear some decrease or some increase in the intensity of sound, which indicates that they are malingering. Okay, so that is your test for malingering. And absolute bone conduction test, as the name suggests, bone conduction, whenever we say BC, it means your sensory neural pathology or sensory neural pathway problems, whereas AC is conductive pathway and sensory neural pathway together. So absolute bone conduction is used for what? It is used for identifying sensory neural hearing loss. So that's how you get to the right answer. We know it's 1B, 2A, 3D and 4C. Right. Match the following. This is again a very, very important thing. Down sloping, up sloping, dip at 2000, dip at 4000. All of them have been PYQs of the past, which is why you're having a lot of match the following types of questions today. So whenever we have normal graph, let's say this is the audiogram that I'm trying to draw. 0 to 20 is what you should check. If your AC curve is between 0 to 20, BC curve is also between 0 to 20, this is going to be normal. So AC curve between 0 to 20, BC curve between 0 to 20, that is normal. Now, if you have a patient who has BC in the normal range, but AC in the abnormal range, what does that indicate? So, BC normal, AC abnormal. What does that indicate? Anybody in the chat box? Where you have a gap between the AC and BC, there is a gap. This we call it as airborne gap. So when there is an airborne gap present, what does it tell you? It tells you the patient has conductive hearing loss. Very, very good. Now, if you have a graph where BC and AC both are abnormal, so BC and AC graphs both are abnormal, they are down sloping. Where do we see that? We see it in patients with presbyacusis. But if we get a graph where BC and AC both are abnormal, but there is an upsloping type of a graph, what does that indicate? That indicates to you that the patient has Meniere's disease, meaning there is a low frequency SNHL. This word is very, very important, low frequency SNHL. Now, if we have a conductive hearing loss where BC is in the normal range, AC is in the abnormal range, but there is a dip at 2000 Hertz. What is this called as? This is called as Kerhart's notch. And where do you get this Kerhart's notch? In otosclerosis. This was a 2024 INI question. Where do you see Kerhart's notch? It is seen in otosclerosis. And then you saw 2023 INI May session. They asked you dip in both AC and BC curve at 4000 Hertz. It indicates to you noise-induced hearing loss. So where are we getting 1C, 2D, 3A and 4B? That is in your option C. So we've revised all the audiograms at one go. Let's move to the next question. A very, very important question on impedance audiometry. Right? So here they're asking to you that there is a patient who met with an accident and this has led to hearing loss in the right ear. On otoscopy, tympanic membrane was intact. Pure tone audiometry showed that the airborne gap was of 55 decibels in the right ear and a normal cochlear reserve. What will be the probable tympanometry finding? I am waiting for your answers. See, I see Laksha answering it as D, Pradhan answering it as A. Let me just explain to you. So after trauma, they said tympanic membrane is normal, right? They have told to you that the patient is having loss of hearing in the right ear. Pure tone audiometry is showing to you an airborne gap. So whenever there is an AB gap, what did we say? There is a conductive hearing loss. They have given you normal cochlear reserve. Normal cochlear reserve means cochlea is normal. They have said you patient is having conductive hearing loss, tympanic membrane is normal, external auditory canal is normal. So now we are thinking that there is some pathology in the middle ear. So after an accident in the middle ear, what could have had resulted to result in a hearing loss? Let's say that the incus and stapes have gotten disconnected because of trauma. What will it result in? Conductive hearing loss? Yes. Will the cochlea be normal? Yes. Will tympanic membrane be normal? Yes. This is the exact situation. So what are we thinking of? Maybe there is an ossicular discontinuity. So for ossicular discontinuity, what type of tympanogram or tympanometry are you going to do? You're going to look for a D type of a tympanogram. So the answer is option D. Where do you get A? A is normal. Where do you get AS? AS is seen in otosclerosis. Where do you get AD? D is seen in discontinuity of ossicle, where you're going to get this D type of graph. Where do you get B type? You get it whenever there is a fluid in the middle ear, and C type whenever there is a Eustachian tubal dysfunction. Right? So I hope everyone is clear with this. Everyone is clear? So this here is your normal A type. This is your AS. This is your AD. This is your C. And if you get a flat line like this, then that is your B type of graph. Okay? So give me a thumbs up if that's clear. Let's go to the next question. Again, this is a 2020 INI question. So please answer. The structure pointed in the image represents lateral semicircular canal, superior semicircular canal, facial nerve, or the sigmoid sinus. Quick. They have given to you a mastoidectomy specimen and they're asking you what do you see in this mastoidectomy specimen. They have marked a structure here which marks the end point of your bony drilling. So what is this structure here? So if you see here, this is your external auditory canal leading to the tympanic membrane. Agreed? This is your mastoid. Correct? The end point where you see you've finished the mastoid surgery is when you see this canal, or when you see that impression of the canal. And what is this impression? This is the impression of your lateral semicircular canal. Okay, so this is the impression of your lateral semicircular canal. What is this sinus that you see here? What is this sinus? This sinus that you see here is going to be your sigmoid sinus. So the sinus that we see here is your sigmoid sinus, and what we see here superiorly, what do we call this plate as? We call this plate as the dural plate. So superiorly we have the tegmen mastoidium that separates the mastoid from the middle cranial fossa, and we call this as the dural plate. This here posteriorly in the posterior border of your mastoid is going to be your sinus plate, and this angle that we have here between the dural plate and the sinus plate, what will we call this angle as? We will call this angle as sinodural angle, also called as Sittelli's angle. So this is your sinodural angle, also called as Sittelli's angle. So when we do the surgery, we look for lateral semicircular canal, we look for the tegmen, we look for the sinus plate, we look for the sinodural angle, and these are the structures which you should be able to recognize in a mastoidectomy specimen. Now if you see here, this posterior canal wall is intact. Now imagine if I remove this posterior canal wall and I make this whole thing into one single cavity. That will be called as modified radical mastoidectomy, also called as canal wall down surgery. Okay, so that will be called as canal wall down mastoidectomy. Okay, so I hope everyone has understood the structures in the mastoid. The structure that you see here is the lateral semicircular canal. The facial nerve will be here, going along the posterior border of the external auditory canal. So any doubt here, anybody? Let's go to the next question. Okay, match the following: ENOG, EMG, electrogustometry, and stapedial reflex. See, these are all the things that you do for facial nerve. To understand whenever there is a facial nerve pathology or whenever there's a facial nerve injury, how are we going to identify what to do, how to do? So electroneuronography, electromyography, electrogustometry, and stapedial reflex. What is ENOG? Electroneuronography is a test where you're giving the facial nerve stimulus and you're going to compare the paralyzed side with that of the normal side. Let's say this is the paralyzed side. So I give facial nerve trunk a stimulus, a electrical stimulus, and I see the contraction. So say this is having about, say example, say 10. And the normal side is having a contraction of 100. Does that mean that there is a 90% reduction in the contraction of the muscles on the disease side? Yes. So if there is a 90% reduction, it means that the chances of spontaneous recovery is very less, so we have to immediately intervene. So ENOG is done in the first weeks to understand should we do any re-innervation procedures or not. If there is 50% reduction as compared to other side, we can still give steroids, you can wait and watch, but more than 90% indicates that the facial nerve will not recover spontaneously and we have to do a re-anastomosis or any procedure that is required. Electromyography. In electromyography, we will see that in the muscle, what kind of potential is present. Is there a fibrillation potential? Is there a proper contraction of the muscle? If there is a fibrillation potential, then it indicates that again the chances of recovery is bleak and we need to again do some active re-innervation procedure. Electrogustometry, it tells us how much is the salivation and it tells us about the taste function of the anterior 2/3 of the tongue. And stapedial reflex, where we see the contraction of stapedius muscle on giving a loud sound, is a topo diagnostic test to understand the function of the facial nerve. So the correct answer is 1B, 2D, 3A and 4C. Now, if I give you a situation like this, a patient who has a lesion above the geniculate ganglion, okay, Let's say there is a pathology above the geniculate ganglion. Somewhere here there is a pathology. What will happen to the rest of the functions of the facial nerve branches? Will GSPN work? No. Will stapedial reflex work? No. Will chorda tympani work? No. And will they have an element type of facial palsy? Yes. So by doing topodiagnostic test, by seeing if the gustation is present or absent, stapedial reflex is present or absent, lacrimation is present or absent, can we diagnose where is the lesion? Yes, that is called as topodiagnosis. Now let's say there is a patient who has a lesion here at point B. What do you think would be spared in these patients? Which nerve function will be spared if there is a suprastapedial lesion? This is the nerve to stapedius. If there is a suprastapedial lesion, what function would not be affected? Very good, Lakshya. Lacrimation would not be affected. So I hope you got what is the meaning of topodiagnosis and all the investigations that we do for functioning of the facial nerve. Yes. Now let's look at the next question. Gradinigo syndrome is seen in, quickly, what is Gradinigo syndrome? Fifth nerve involvement, sixth nerve involvement with persistent otorrhea. Where do we see this? This is seen in petrositis. So whenever there is an inflammation of the petrous apex, at the apex of the petrous bone, we have the fifth and the sixth nerve. And whenever there is a petrositis, fifth and sixth nerve will be involved, resulting in temporoparietal neuralgia, lateral rectus palsy, and persistent ear discharge. And this we call it as Gradinigo's triad or Gradinigo's syndrome. Okay, where do you get hectic picket fence type of fever? Hectic picket fence type of fever is seen in lateral sinus thrombosis, where there is a continuous fever that does not touch the baseline. This is the baseline and it spikes because of release of embolus into the circulation, which is a septic embolus. We see it in lateral sinus thrombophlebitis. Remember, abscesses in relation to mastoid. If the pus goes into the sternocleidomastoid, we call it as the Bezold's abscess. Then we can remember Citelli's begins with C, it ends with D. So Citelli's abscess is digastric abscess. After alphabet L comes M. So Lux abscess is meatal abscess. So I hope all the complications related to mastoid, related to abscesses, gradinigos and lateral sinus thrombosis, main points have been covered over here. Okay. Now match the following. Embolization followed by surgical excision is the treatment of choice for which condition? Radiosurgery for which condition? Anti-pseudomonal drugs with debridement, intratympanic gentamicin with endolymphatic sac or endolymphatic sac decompression is done in which disease? See, we are doing the treatments of various diseases and identifying what conditions, what surgery or what treatment is done. So embolization followed by surgical excision is the treatment for glomus tumor. So 1A is 2. So A2 is only seen in these options. So we rule out these A and B. Let's look at radiosurgery. Single large dose of radiation, we call it as radiosurgery. It is done for acoustic neuroma. So it is B4. So the only option which has is option D. C3, anti-pseudomonal drugs is given for malignant otitis externa, and intratympanic gentamicin or endolymphatic sac decompression is done for Meniere's disease. Okay, I think that was pretty simple. A patient with recurrent sinusitis, nasal ulceration, epistaxis and lung infiltrates. Again, this is a PYQ, INI-CET PYQ. Can you answer what is the diagnosis? This has come also in NEET 2025, same question. Yes. So when there is sinusitis, ulceration, they have given in NEET saddle nose deformity. They did not say ulceration or they did not say, septal perforation. What they used is saddle nose deformity. So whenever they're telling you saddle nose deformity, you should think that there is some destruction happening, and that destructive disease is your granulomatosis with polyangiitis called as vaginous granulomatosis. Chronic sinusitis can have sinus issues, they can have epistaxis, but why would they have lung infiltrates? Polyps again can have sinusitis, they can have asthma, but can they have infiltrates in the lung? No. Allergy, of course, can have, asthma associated, but they won't have any epistaxis and lung infiltrates, which is why the right answer is granulomatosis with polyangiitis. This vaginous granulomatosis involves the entire septum. So it causes entire septal perforation. Normally, all the diseases like cartilage, like your TB or your leprosy, will affect the cartilaginous portion of the septum. Syphilis is the only disease that affects the bony portion of the septum, and entire or total septal perforation is seen in vaginous granulomatosis. Yes, that is right. C Anka is done for vaginous. A patient underwent FES for CRS, which is chronic rhinosinusitis, and after 2 years, the patient presented to you with headache and proptosis. CT image is given below. What is the probable cause? So they have done a surgery. After surgery, there is, headache and there is proptosis of the eye. You can see here the CT scan is showing to you something significant. What is it showing to you? You can see here that there is a opacified area near your ethmoidal sinus that is pushing the eye outwards. So what is the probable cause? Why is this happening? Following any sinus surgery or following any trauma, there is always a possibility that there could have been, narrowing or stenosis of the drainage. Now let's say frontal or the ethmoidal drainage, if they are blocked, maybe because of adhesions, maybe because of synechia, this can be because of post surgery, post trauma, because of anything. Now what will happen? There will be retention of secretion, and that retention of secretions within an epithelial lined sac, what will we call it as? Mucocele. And what will mucocele do? It will press on the adjacent areas to cause proptosis. Here we will get a feeling on palpation. What do we call that as? Eggshell cracking feeling. That word will be used in your exam. Eggshell cracking feeling is seen in mucocele. Right? Now, why not recurrence of CRS? Because if there is recurrence, you would not just see in one sinus, you would probably see in all the sinuses, and there is no reason for proptosis for recurrence. Allergic fungal will show you typically double density is not single density. Single haziness, there will be area which are dark white and bright white. Osteoma is completely white. It is not gray, it is completely white. So that is why the answer is mucocele. Right? Okay, match the following. Septoplasty, what will you do? Or what is the match the following? Septoplasty, SMR, incision and drainage with compressed nasal packing, incision and drainage with IV antibiotics. So septoplasty is a surgery that is done for any deviations which are anterior to the Cottel's line. What is Cottel's line? It is a line imaginarily drawn from the frontal spine to the anterior nasal spine. So you draw an imaginary line like this. Any deviations anterior to it is treated only with septoplasty. Any deviation posterior to it is treated either with septoplasty or SMR. So septoplasty, deviations anterior to the Cottel's line, SMR posterior, incision and drainage with compressed nasal packing is done for a hematoma, and IV antibiotics should be given for septal abscess. So the correct answer is A2, B1, C3 and D4. Now just to give you an idea, septal abscess, septal hematoma, both of them will have a bulge. Let's say this is the septum. On either side of the septum there will be a bulge. Same clinical image will be given to you. Both of them will have nasal blockade, both of them will have pain. But if there is an additional fever, headache, lymphadenopathy, then it should tell you about septal abscess. And for septal abscess, very important is antibiotics. You don't do compressed packing. If they give you only this, they do not give you any fever, headache, lymphadenopathy, then you should think of septal hematoma. And here what is important is compressed nasal packing, right? So that's about it. Let's go to the next one. Match the following. Partial turbinectomy, Lautenschlager's operation, Caldwell operation and FES operation. Again, the steps of FES was a NEET question. This was asked in the NEET. So you should know about the steps of FES. So partial turbinectomy, meaning you're reducing the turbinate partially, that is done for hypertrophic rhinitis. In conditions wherever the turbinate is partially enlarged, we're going to do this, which is your hypertrophic rhinitis. Lawton-Slager's operation is a surgery that we do for atrophic rhinitis. So in atrophic rhinitis, there is atrophy of the mucosa of the nose, of the turbinates. So there is a wide nasal cavity. So to narrow the nasal cavity, we push the lateral wall medially, and that surgery where we push the lateral wall to the midline, we call that surgery as Lawton-Slager's operation, which is done for atrophic rhinitis. Caldwell's Sluck operation is an operation where you go through the sublabial route to approach the maxillary sinus, and FES, functional endoscopic sinus surgery, is a surgery that is done to open up all the sinus. So in FES, what do we do? In FES, the first step will be to open the uncinate. So this is the gateway to the middle meatus. Only when you remove the uncinate process will you be able to see the bulla ethmoidalis. Now what do you do? After identifying the removing the uncinate, you open the maxillary sinus ostium and do a maxillary sinusotomy. And where does the maxillary sinus open? In the infundibulum. So the first step will be uncinectomy, where you remove the uncinate. The second step will be infundibulotomy, where you open the infundibulum to open the maxillary sinus. Then you remove the anterior ethmoids, posterior ethmoids, and the sphenoid sinus opening, and finally you come back and open the frontal sinus opening. So these are the steps that you will do for FES. Okay, let me just come back to the right answer. 1B, 2A, 3D and 4C, that's the right option. Okay, a patient was diagnosed with squamous cell carcinoma of the nose and paranasal sinuses. The patient's prognosis was determined using Ongren's classification. According to this classification, which of them may indicate good prognosis? So what is Ongren's classification? There are two imaginary lines which are drawn from the floor of the nose and floor of the maxillary sinus, right? So this is your first imaginary line. Then you have got another imaginary line going through the floor of the orbit and floor of the maxillary sinus, right? The higher the malignancy, poor is the prognosis. Lower the malignancy, better is the prognosis. So alveolar, near your teeth, of course, is the lowest. So it will have good prognosis. Maxillary part of nose, okay. Ethmoid will have lesser or poorer prognosis as compared to these two, and the worst will be olfactory area, which is present in the roof of your nose. Got it? So the best one is alveolar process. A female presented to you with nasal obstruction. On examination, there's a large nasal cavity. So whenever you get large nasal cavity, female, foul smell, patient is not able to perceive that smell, which we call it as merciful anosmia. There is microcytic anemia, which is the cause of this. Along with that, there is vitamin D deficiency indicating her cause. What is the disorder she's suffering from? The answer is atrophic rhinitis. And atrophic rhinitis is caused by which organism? Klebsiella oziana. Correct? So this is caused by Klebsiella oziana, also called as which bacillus? Perry's bacillus. There is another organism, Klebsiella rhinoscleromatis, which is also called as Frisch bacillus. Okay. Now match the following. These are some congenital anomalies, and now you're supposed to identify the respective diagnosis. If there is respiratory distress at rest but disappears on crying, this we call it as cyclical cyanosis. Very, very important. Where do you see cyclical cyanosis? This is seen in choanal atresia. So which option is showing to you? 1B, A and D. So we rule out B and C. Compressibility test positive, transillumination test positive is seen in encephalocele. Now you might ask me why. Encephalocele is a congenital anomaly where there is herniation of brain. Now brain is a soft structure, so compressibility test will be obviously positive. Now why is transillumination test positive? Now if you see, the brain is surrounded by fluid which is called as your cerebrospinal fluid. So whenever you put light, it will transmit the light, making it illuminant, so transillumination test will be positive. Now, if you have a swelling which has transillumination test negative but compressibility test positive, it is going to be your dermoid because it is having toothpaste like cheesy, soft, sebaceous material. So compressibility test will be positive. But because there is thick, cheesy material, transillumination test is negative. Glioma is firm in consistency because the nasal immune cells recognize these CNS cells as foreign cells and they fight against it to cause fibrosis, and because of that it is firm in consistency, and since it is firm in consistency, compressibility and transillumination is negative. So 1B, 2A, 3D and 4C, that is your right answer. Got it? Okay, match the following. Sinus absent at birth, earlier sinus to be developed, most pneumatized sinus, sinus having a high opening. So sinus absent at birth are both frontal and sphenoid, both of them are absent at birth. But now how do we choose? You just have to look at the last one, which is the sinus having a high opening. So the highest opening is frontal, right? So you now know that 4 goes to C. Absent at birth will be sphenoid. Earliest to be developed is maxillary and most pneumatized is your rhythmoid, making your option B the right answer. Got it? Everybody got it? 1D, 2A, 3B and 4C. If you see here, this is the frontal sinus. This is the opening of the frontal sinus. Posteriorly, you have the opening of the sphenoid sinus. So which sinus is having a higher opening? Is it the frontal or is it the sphenoid? It is the frontal. Got it? Okay. Match the following. It's not Caldwell luck, it's Caldwell's view, which is occipitofrontal view. So where do you do this occipitofrontal view to best visualize which sinus? It is for your frontal sinus. Waters view, it is for which view? Occipitomental view. It is for which sinus? It is for your maxillary sinus. Lateral view, it is done for which sinus? Sphenoid sinus. This one is A2, B3 and C1. That's the right answer. What is the most common organism for acute sinusitis? So what is the most common cause of fungal sinusitis? It is Aspergillus. Okay. So that's about it. Let's go to the next question. Look at this fracture and tell me what kind of fracture is this. Where do you get guardsman fracture? Is it in image 1 or image 2, image 3 or image 4? At least just tell me that. What is guardsman fracture, also called as parade ground fracture, where there is a fracture at symphysis menti and bilateral subcondylar fracture? So which image is showing to you that? It is image 3. So guardsman fracture is your image 3. Here in the image 1, we are seeing a fracture which is running horizontally. So horizontal fracture of the nasal septum is Jargevet's fracture. Vertical fracture of the nasal septum is Chevalier's fracture. And if you have a fracture which is having 3 fracture lines like this, what do we call this fracture? Where there is a fracture at the zygomaticofrontal region, zygomaticomaxillary and zygomaticotemporal, which is in the form of a tripod. What do we call this fracture as? Tripod fracture. So this is going to be your tripod fracture, which is nothing but fracture of the zygoma. So A is going to be your image 3. B is going to be image 4. Jargevet's fracture is nothing but your horizontal fracture. Chevalier's fracture is the septal fracture. Got it? A 10-year-old boy accompanied by his mother presents to you with complaints of fever, sore throat, fatigue and difficulty in swallowing for the past 2 days. Past medical history is insignificant and there is no history of recent illness or travel. Vitals are showing 105 per minute of pulse rate, BP is 90/60, respiratory rate is fine, but there is a temperature which is 102. Physical examination shows cervical lymphadenopathy with red tonsils. What is the late complication of this condition? So we are talking of what here? We are talking of acute tonsillitis. Because the age is 10, the patient has fever, the patient has sore throat, the patient is having difficulty in swallowing, the child is also having, fever, which is 102, high grade fever, red swollen tonsil on examination, all of that suggests to you acute tonsillitis. What is the organism that is responsible for causing acute tonsillitis? It is group A, beta hemolytic streptococcus. So this group A beta hemolytic streptococcus has got what? It has got cross-reactive antigens against myocardium, glomerulus and joints, and as a result, on a long term, what could that result in? It could result in valvular heart disease, right? So that's about your question here. A 3-year-old boy presents to you after having swallowed a circular metallic foreign body, and he points to you of pain at the sternal notch area when asked where it hurts. What is the most worrisome complication in this type? So whenever they give you circular foreign body, something should strike to you in a 3-year-old child. Should we think of button battery? So whenever you're thinking of a button battery, can it cause esophageal perforation and mediastinitis? Yes, that is the right answer. Let's go to the next question. A patient presents to you with a history of recurrent tonsillitis and has undergone tonsillectomy. The patient presented to you with secondary hemorrhage. When does secondary hemorrhage occur? 6 hours after surgery, 24 hours of the surgery, 6 days after, or 14 days after. So any hemorrhage that happens intraoperatively, what do we call it as? Primary hemorrhage. Any hemorrhage that happens within 24 hours, what do we call it as? Reactionary. And anything that happens after 24 hours up till 14 days, what do we call it as? We call it as secondary. So here they're asking you about secondary. So what should the answer be? C. Right? After 14 days, we are not having any sort of hemorrhages happening. So until 14 days is going to be your secondary. Got it? 24 hours of surgery. I didn't say after. I made the change in the statement. 24 hours of surgery, right? So the correct answer is option C. Got it, everybody? Intraoperative hemorrhage, you are going to ligate the bleeding vessel. Usually the peritonsillar vein or the tonsillar artery bleeds. Reactionary hemorrhage, you have to immediately re-explore because there could be slippage of the ligature. So you have to take back the child to the operating room, and anything that happens beyond 14 days or beyond 24 hours up to 14 days, you call it as secondary hemorrhage, which is because of infection, and you're going to treat the infection. Okay, a diabetic patient with history of tooth extraction presented with swelling in the neck over the upper third of the sternocleidomastoid, and there is displacement of tonsil to the opposite side. What is the diagnosis? Yes, quickly answer. What is the diagnosis? There is displacement of tonsil. So whenever you get a swelling of the tonsil or unilateral bulge of the tonsil and there is a neck swelling also, what should you think of? Yes, parapharyngeal abscess. So whenever you get a unilateral bulge, there are two differential diagnoses. One is your peritonsillar abscess, also called as quinsy. The second one is parapharyngeal abscess. In quinsy, there will be no neck swelling. But in parapharyngeal abscess, there will be neck swelling. So with this, we know the answer is nothing but your parapharyngeal abscess. Now look at the images and match the following. So at least look at the first image where you see that there is a prevertebral soft tissue shadow. This has gotten enlarged more than 2 times the size of the body of vertebra. You see some air bubbles here. What is your diagnosis here? This is going to be your retropharyngeal abscess. Now look at the image here. You see there is an anterior bowing of posterior wall of maxillary sinus. What does this say you? Anterior bowing of posterior wall of maxillary sinus. What is this sign called as? Hallman-Miller sign. And where do you get this Hallman-Miller sign? In JNA. Correct? So that's your JNA. Now look at this image where you see that in the nasopharynx there is a soft tissue shadow here that is occupying almost the complete size of the nasopharynx. What is this? With crowding of the teeth, what does this indicate? This indicates to you adenoid hypertrophy. And look at this image where you see that there is a soft tissue lesion that is going inside the nasopharynx, probably coming from the maxillary sinus, but there is an air column between the mass and the posterior pharyngeal wall. What is this? This is nothing but your Dodds sign. And where do you get this Dodds sign? It is seen in AC polyp. So I think images are clear to you. Radiological images of AC polyp, adenoid, Dodds sign, and retropharyngeal abscess. Yes, that's about it. Let's go to the next question. A 60-year-old female presented to you with hearing loss and discharge in the left ear. There is diplopia and neuralgic pain on the left side of her face. Rinne and Webers were done, which indicate to you that the patient has a conductive hearing loss. I think this is very easy. We've already done. What is the diagnosis? Yes, they're talking to you about Gradinego syndrome, where there is fifth nerve involvement, sixth nerve involvement, lateral rectus palsy. So we are talking about Gradinego syndrome. What is Lermois syndrome? It is a variant of Meniere's disease where instead of having vertigo, sensorineural hearing loss, and tinnitus, the patient has reverse of symptoms. The patient has tinnitus followed by sensorineural hearing loss followed by vertigo. That is called as your Lermois syndrome. What is Trotter's triad? It is seen in nasopharyngeal cancer where the patient has fifth nerve involvement, 10th nerve involvement, and conductive hearing loss. That is your Trotter's triad seen in NPC. Okay. During routine nasal endoscopy, clinician asks the patient to swallow and the Eustachian tubal orifice is open. What is the innervation of the muscles that are responsible for this observation? So there are two muscles that will help in opening the Eustachian tube. Which are those two muscles and what are these muscles innervated by? So normally Eustachian tube is collapsed, but there are two muscles which will help to open it, which is your tensor veli palatini and levator veli palatini. Right, so tensor veli palatini is supplied by your fifth nerve, levator veli palatini is supplied by your 10th nerve. So the nerves that are responsible for opening the Eustachian tube is going to be the vagus nerve and the trigeminal nerve. Got it? Let's go to the next question. A 60-year-old man presents to the clinic with a 5 centimeter solitary lymph node in the upper right cervical region and an abnormal looking right tonsil. Assuming this is squamous cell carcinoma nodal metastasis, what is N classification? Is this N1, N2A, N2B or N2C? I'm waiting for your answers. Normally N0 means there is no neck node. N1 is the size of node is less than 3 centimeter. N2 is 3 to 6 centimeters and N3 is more than 6 centimeters. Now because they have given you 5 centimeter, N1 and N3 is ruled out. Now in N2 you have 2A, 2B and 2C. What is 2A? If there is a single node and an ipsilateral node. Here they have given you word solitary. Yes. Where is the node? On the ipsilateral side, right side. Which tonsil is abnormal? Right. So right tonsil carcinoma, right node, ipsilateral node, single node. What does it favor? 3 to 6 centimeter. The answer is N2